Hi, I'm Ellen Scherl. I'm the director of the Jill Roberts IBD Center at NewYork-Presbyterian Hospital, both at the Weill Cornell Medical College and an adjunct professor at the Columbia University Medical College as well. Today, we're going to kick off the first New York-Moscow IBD Journal Club that was envisioned and discussed at the 10th Congress of Gastroenterological Scientific Society of Russia in March of 2010. I'd like to thank Dr. Leonid Lazebnik for having the vision to include this as part of the agenda for today's conference and going forward over the next year. I'd like to also specifically thank Peter Holt from Rockefeller University, who introduced me to your GSSR. In 2010, Emmett Keefe was also present in Moscow at some of these discussions. This has, the Journal Club and Case Discussion Series has the backing of the GSSR as well as the AGA and the Central Scientific Research Institute of Gastroenterology. The AGA is the American Gastroenterologic Association. So this is a true collaborative, transatlantic endeavor, and we are thrilled to continue this enterprise. I do want to acknowledge that we have weekly or bi-monthly journal clubs at both the Columbia and Cornell campus. Dr. Brian Bosworth and Vanita Jacob at Cornell and Dr. Arun Swaminath at Columbia are key players in keeping our debates lively and keeping the GI fellows on point, and we look to do the same with your young scientists as well. So the idea is to engage in a lively debate focused on patient-based cases and then relevant literature. And our format has been to try to take a classic article and then contrast it with a newer article that, again, analyzes the data relevant to the case discussion. So today, we're going to introduce the concept of treatment in fulminant ulcerative colitis, and we will start with two questions, namely, what % of ulcerative colitis patients actually require colectomy after their first severe attack, and is there a prodromal symptom onset before ulcerative colitis? So I'm going to present a 19-year-old patient who was in excellent health and came to our center with the new onset of persistent diarrhea after a service mission in Guatemala. Now, everybody on this college-based mission developed gastroenteritis, and everyone was treated with empiric ciprofloxacin. Most got better. Her non-bloody diarrhea continued, and she had a culture and sensitivity test that was negative. After 3 weeks, her symptoms continued, and she had a second course of antibiotics, this time Cipro and Flagyl, followed now by bloody diarrhea. At no point did she have an interventional endoscopy at this time. But after 4 weeks of diarrhea, so mostly non-bloody, one of continuous bloody, she presented to the emergency room and actually had a severe anemia with a hemoglobin of 5. So one question is this an infectious Salmonella, Shigella, or Campylobacter, or even C. diff colitis that was contracted as she traveled? Or was this a severe case of ulcerative colitis with or without an intercurrent infection? So in the emergency room, as a GI fellow called into consultation, the first recommendation is IV hydration, potassium replacement, stool cultures for 3 times, including C. diff, an abdominal x-ray, and then a flexible sigmoidoscopy. Just the very bottom of the rectum needs to be intubated, 10 to 20 centimeters if you see pathology. And she had severe ulcerative colitis, hemorrhagic colitis. The diagnosis cannot be established on endoscopy alone. A biopsy must be taken to establish the diagnosis. And certainly in this case, you want to rule out amoebic colitis with her travel to Central or South America. Again, biopsies show the classic crypt architectural distortion with multiple polymorphonuclear infiltrate, and you can see plasma cells in the plasma cell plasmacytosis so that the crypt base is separated from, this is the crypt base, separated from the lamina propria by this plasma cell infiltrate. Classic diagnostic for ulcerative colitis. Again, plasma cell infiltration separating the lamina propria from the base of the crypts. What differentiates acute from chronic inflammatory bowel disease is that acute infections usually occur less than 2 weeks, and the biopsies show predominant neutrophils, whereas in inflammatory bowel disease there may be predominant neutrophils, but also lymphocytes and then the plasmacytosis. And the key is that the crypt architecture is markedly distorted. So this is a biopsy that shows the crypt architecture lined up like test tubes or six-packs, and this is a diagnosis of an infectious colitis. And again, you can see that the base of the crypts right here is right next to the lamina propria, muscularis mucosa, again suggesting that this is infectious, not ulcerative colitis. And here's where the key biopsies come in. This is a patient who has pseudomembranous colitis, and again, I just draw your attention to the crypts that are not distorted. So we need to be vigilant of ruling out C. diff not only at the initial diagnosis, but as a patient flares as well. Now, in terms of determining severity of inflammation, this patient we know has severe disease. She has more than 10 bowel movements a day. She's bleeding, and she is complaining of abdominal distension, and she's anemic. So there are several criteria to determine mild, moderate, and severe, but again, the weight loss, tachycardia, and elevated sed rate, and more than 6 bloody bowel movements a day are what make this patient severe. And just to reiterate, this is a beautifully normal colonoscopy with a beautiful arborization of the vascular pattern. The first sign of ulcerative colitis is loss of that vascular pattern and some friability. Moderate disease is seen here, and severe, again, deep ulcerations you can see, and multiple friability and bleeding. On X-ray, you will see distension in moderate to severe toxic colitis, and this will also give you an idea of how extensive the disease is, and that's why the abdominal X-ray must be done on the emergency visit. So in terms of treatment for moderate to severe ulcerative colitis, we tend to recommend steroids and either oral or intravenous. The issue here is that if you're going to use steroids, you need to have an exit strategy. Why do we use steroids? Because the majority of patients have a dramatic response. We're talking about 80% of patients having a response to steroids and ulcerative colitis within a month's time. The problem is at the end of a year, only 50% have a prolonged response, and of the 50% that are either steroid dependent or steroid refractory, 30% actually make up the steroid refractory group, and this is results in colectomy. This is pre-6-MP azathioprine, and certainly this data is before Infliximab. And one of the questions that we need to ask is whether Infliximab is going to change the way we treat ulcerative colitis in terms of diminishing hospitalization and colectomy rate. So with the advent and introduction of steroids in 1950, it was felt that steroids changed the natural history dramatically, acutely, so that the morbidity and mortality rate was as high as 35% before the introduction of steroids. With the advent of steroids, that number went down to less than 1%. But steroids have not changed the long-term chronic ulcerative colitis history, and that does include that inexorable course toward colectomy. So the exit strategy, if you have a patient in the hospital and they're not responding to 3 days of IV steroids, you need to think about an exit strategy, either colectomy, cyclosporin, or Infliximab. 5 to 7 days of IV steroids if a patient has a partial response is acceptable. But again, if you don't induce remission, there is no way that you can maintain remission, and that's something that we need to think about in terms of exit strategies as well. This patient was started on a hydrocortisone drip every 8 hours. All cultures were negative. Biopsies confirmed ulcerative colitis. We did start Cipro and metronidazole because until we got back the cultures and the biopsy, I think that was a reasonable strategy. Now, after 3 days, there was not a significant response. And what would happen, and we can open this up to a discussion, do you continue steroids? I think the literature suggests otherwise, but most of us in practice still do that. IV steroid, cyclosporin, or anti-TNF. Well, this patient was discharged after 1 week of IV steroids with only a partial response, and she was discharged on high-dose prednisone, 70 milligrams. After 3 weeks of between 60 and 70 milligrams, she continued to have severe bloody diarrhea, and her hemoglobin decreased from 9 to 5. She was hypoalbuminemic, severely Cushingoid, and depressed. So now when she comes to the emergency room, she has a toxic hemorrhagic colitis. And again, this is a real case, prolonged steroids and high-dose steroids, ineffective therapy. So steroids work in about 80% of patients, but when they don't work, there's no reason to persist. And so here you can see toxic colitis with perforation. She had a CT scan showing intramural air, but she actually had not perforated. And of course, the idea is to diagnose the perforation before it actually perforates. So what does this patient want to know? Can she live without a colon? Does she need the whole colon out? Well, the fact is she had left-sided colitis, but still she needs the whole colon out. And in this case, she can live without her colon, and she actually cannot live with her colon. So what we need to try to convey to this depressed Cushingoid patient is that actually this discussion that we're having is not about saving her colon, it's about saving her life. And we need to reassure her that she can actually live a better life without her colon, and her quality of life will improve. And there are studies that we can review at a separate time discussing the quality of life with colectomy in patients like this with severe fulminant, hemorrhagic, or toxic colitis. What are her surgical options? At this point, her only option is a subtotal colectomy to remove the abdominal part of the colon and leave the rectum in place. This is the procedure that she will have, a subtotal colectomy with the rectum in place. At another time, she will have a creation of the J pouch and removal of the rectum, usually 3 to 6 months after the original surgery. And some surgeons will do a diverting ileostomy to protect the pouch. And then at yet another time, she will have a third stage, which will be the ilioanal pouch and closure of the ostomy. Can this procedure be done as a one-stage? Yes. And usually it can be done as a one-stage in patients who have dysplasia and no active colitis, but it can be done sometimes in a one-stage with more moderate disease, not in somebody who is this sick. So she underwent a subtotal colectomy, had deep ulcerations, microperforations, and fulminant colitis. And the diagnosis was ulcerative colitis on pathology. Now, this is a young woman, although she's not married. At some point, she will want to have a discussion about marriage and childbearing. And of course, you remember that these diseases, both ulcerative colitis and Crohn's disease, occur in the prime of patients' lives, mid-teens to early 30s, just when they're getting married, going through college, and contemplating having families. So patients who undergo an ilioanal pouch anastomosis do have a decrease in fecundability over a 5-year period of time. This is a study that Olson did, and it may be that if you do a 3-staged procedure rather than a 1 or 2-staged, there may be decrease in change in increased fertility, but this needs to be studied further. So now the case, and now we will discuss some of the literature around fulminant ulcerative colitis and what the medical options are. This is a review article in Clinical Gastroenterology and Hepatology in 2009 with Scott Plevy and Millie Long, and they present a different case, but the problem is the same. lifetime risk of severe ulcerative colitis exacerbation requiring hospitalization is 15%, and in hospitalized patients who are refractory to IV steroids with an exit strategy of around 3 days, the medical options are either cyclosporin or Infliximab if you want to avoid colectomy. Again, characteristics that are correlated with a likely loss of response or non-response to steroid are frequent bloody bowel movements, hypoalbuminemia, tachycardia, fever, and colonic dilation. So after 3 days of IV steroids, 85% of patients who continue to have frequent bowel movements as well as bloody bowel movements are likely to have a colectomy. Cyclosporin can be used as an alternative in refractory ulcerative colitis patients who are failing steroids. Again, this can be used at both 4 and 2 milligrams per kilogram. And in the original Lichtiger trial, which was a small trial of patients being rolled into the OR, about 85% of patients who received 4 milligrams per kilogram of cyclosporin were spared a colectomy, and in the placebo group, everybody got a colectomy. It was felt that it was unethical to continue that study, and so cyclosporin has been studied since that time, but that was a small, pivotal trial that put cyclosporin on the map as a medical salvage therapy for steroid refractory ulcerative colitis patients. And we learned very rapidly that the cyclosporin must be used as a bridge to maintenance 6-MP azathioprine. In terms of cyclosporin toxicity, the major adverse events are infections, especially as you combine it with steroids and 6-MP or azathioprine. So PCP, pneumonia has to be prophylaxed for. Nephrotoxicity needs to be watched for in the hospital and also as the patient is on oral cyclosporin as a transition to 6-MP or azathioprine. Seizures are associated with low cholesterol and hypomagnesemia. Anaphylaxis has been described. And these are very powerful medications that need to be watched closely. What about Infliximab for severe ulcerative colitis? It is an attractive option to monitoring cyclosporin every other day in terms of levels, looking at magnesium and cholesterol levels, and watching the kidney closely in the hospital. There is a decrease in colectomy rates for patients with severe ulcerative colitis. 67% can be spared a colectomy if Infliximab is used. And we're going to go over that data. But here is the comparison of cyclosporin, up to 86% of colectomy avoidance, whereas Infliximab is effective in about 50% of patients, different patients entering these trials. Indication for colectomy: free perforation, toxic colitis, hemorrhage, patients who are unstable, as the patient that we're describing with hypoalbuminemia and severe anemia. Urgent indications are patients who are failing to respond to medical therapy. The procedure of choice is a subtotal colectomy and then an interval ileoanal pouch anastomosis. Most patients who have severe or moderate to severe active ulcerative colitis who undergo an ileopouch anal anastomosis feel that the quality of their life improves. So, this is the trial that we alluded to. This is a Janero trial looking at Infliximab in moderate to severe ulcerative colitis. It's a randomized trial compared to placebo, and it was published in Gastroenterology in 2005. So the endpoint was to look at patients who had failed steroids in terms of colectomy versus colectomy avoidance. And again, it was a randomized double-blind controlled trial where half the patients were randomized to get 5 milligrams per kilogram of Infliximab and the other half got placebo, in other words, continuing their steroids. The age of inclusion was 18 to 75. The CO index was used to predict ulcerative colitis scoring system and disease activity. And patients were, by the most part, they had prior ulcerative colitis, and the disease tended to be extensive, and the patients were evaluated at 3 months from induction. And what you can see here is that 71% of patients with Infliximab avoided colectomy, whereas 67% in the placebo underwent colectomy. This study then resulted in further studies looking at large controlled trials comparing Infliximab to placebo, and that is the Act 1 and Act 2 trial, which we will discuss at another time. The adverse events with Infliximab, there was one central line septicemia. With the placebo, there were also infectious complications and one reoperation due to septic complication. The limitations of this study is that it's a small number of patients, only 43 patients in the trial, and it's a short-term trial. This has led, as I mentioned, to the long-term trials of Act 1 and Act 2, which will give us the one-year data that actually has led in the United States to the FDA approval of Infliximab for moderate to severe ulcerative colitis. Thank you very much, and I look forward to discussing this and would like to open this up to an interactive dialogue now. Thanks.